Hello, good evening. This is Ramavath Abhilash. I'm a second year medical student. What's your name?
I'm Praveen,
What's your age?
22 years.
Okay, today I'm going to examine your shoulder. Is that okay with you?
Okay.
Okay, do you have any pain in your shoulder?
No.
Okay, shall I examine now? Okay, please remove your shirt. First, inspect the shoulder and shoulder girdle anteriorly, then the scapula and related muscles posteriorly. Note any swelling, deformity, muscle atrophy, or fasciculations or abnormal positioning. Look for swelling of the joint capsule anteriorly or a bulge in the subacromial bursa under the deltoid muscle. Also look at for the change in the skin color. Now start palpation. Beginning medially at the sternoclavicular joint, trace the clavicle laterally with fingers. From behind, follow the bony spine of the scapula laterally and upward until it becomes the acromion, the summit of the shoulder. Its upper surface is rough and slightly convex. Identify the anterior tip of acromion. Also palpate the spine of the scapula and coracoid process, greater tubercle and bicipital tendon and subacromial bursa. And also palpate the underlying sits muscles. Palpate the capsule and synovial membrane beneath the anterior and posterior acromion to check for injury or arthritis. Shoulder girdle range of motion. First flexion and extension, abduction and adduction. Now external rotation and internal rotation. In crossover test, adduct the patient's arm across the chest and ask if they feel any pain. In apply scratch test, ask the patient to touch the opposite scapula using the two motions, one from upside and another from downside. Pain during these maneuvers suggests a rotator cuff disorder. Now knee impingement test. Press on the scapula to prevent scapular motion with one hand and raise the patient's hand arm with the other. This compresses the greater tuberosity of the humerus against the acromion. Now Hawkins impingement test. Flex the patient's shoulder and elbow to 90 degrees with the palm facing down. Rotate the arm internally. In drop arm test, ask the patient to fully abduct the arm to shoulder level up to 90 degrees and lower it slowly. Note that abduction above shoulder level from 90 degrees to 120 degrees reflects action of the deltoid muscle. Now empty can test. Elevate the arms to 90 degrees and internally rotate the arms with the thumbs pointing down as if emptying a can. First, inspect the position of the hands in motion for smooth, natural movement. When the fingers are relaxed, they should be slightly flexed. The fingernail edges should be in parallel. Note any deformities of the wrist and observe the thenar and hypothenar eminences. Inspect the palmar and dorsal surface of the wrist and hand carefully for swelling over the joints or signs of trauma. Now start palpation. Palpate the radial styloid bone and the anatomic snuff box, a hallowed depression. Palpate the 8 carpal bones lying distal to the wrist joint, and then each of the 5 metacarpals and the proximal, middle, and distal phalanges. Palpate any other area when you suspect an abnormality. Note any swelling, bogginess, or tenderness in the fingers. Examine the fingers and thumb. Palpate the medial and lateral aspects of each proximal interphalangeal joint between thumb and index finger. Again, checking for swelling, bogginess, and bony enlargement or tenderness. And also look at for the Heberden nodes. In any area of swelling or inflammation, palpate along the tendons, inserting on the thumbs and the fingers. Tenderness and swelling occur in tenosynovitis or inflammation of the tendon sheaths. And also palpate the distal interphalangeal joints. Distal interphalangeal joints are involved in psoriatic arthritis. Wrist range of motion: flexion, extension, adduction or radial deviation, and last abduction or ulnar deviation, and pronation and supination. In test hand grip strength, ask the patient to grasp your second and third fingers. This test function of wrist joints, the finger flexors, and the intrinsic muscles and joints of the hand. Finkelstein test. To test thumb function, ask the patient to grasp the thumb against the palm and then move the wrist towards the midline in ulnar deviation. To test thumb abduction, ask the patient to raise the thumb straight up as we apply downward resistance. To test Tinel sign, by tapping lightly over the course of the median nerve in the carpal tunnel. Aching and numbness in the median nerve distribution is a positive test. To test Fallon sign, ask the patient to hold the wrist in flexion for 60 seconds with the elbows fully extended. Alternatively, ask the patient to press the backs of both hands together to form right angles. These maneuvers compress the median nerve. Now, examination of knee. First, start inspection. Inspect the joint for a smooth rhythmic flow as the patient enters the room. The knee should be extended at heel strike and flexed at all other phases of swing and stance. Inspect for any loss of the normal halos around the patella, a sign of swelling in the knee joint, and suprapatellar pouch. Note any other swelling in or around the knee. Now start palpation. Ask the patient to sit on the edge of the examining table with the knees in flexion. In this position, bony landmarks are more visible and the muscle tendons and alignments are more relaxed, making them easier to palpate. Pay special attention to any areas of tenderness. Pain is a common complaint in knee problems. Now palpate the tibiofemoral joint. Facing the knee, place your thumbs in the soft tissue depression on either side of the patellar tendon. Identify the groove of the tibiofemoral joint. Note that the inferior pole of the patella lies at the tibiofemoral joint line. As we compress thumbs downward, we can feel the edge of the tibial plateau. Follow it medially then laterally until you are stopped by the converging femur and tibia. And note any irregular bony ridges along the joint margins. Now palpate the medial meniscus. Press on the medial soft tissue depression along the upper edge of the tibial plateau with the tibia slightly internally rotated. Place the knee in slight flexion and palpate the lateral meniscus along the lateral joint line. And also palpate the medial femoral condyle. The adductor tubercle is posterior to the medial femoral condyle. Move thumbs downward to palpate the medial tibial plateau. Now palpate for any thickening or swelling in the suprapatellar pouch and along the margins of the patella. Start 10 centimeters above the superior border of the patella, well above the pouch, and feel the soft tissues between the thumb and fingers. Move hand distally in progressive steps, trying to identify the pouch. Continue palpation along the sides of the patella and note any tenderness or increased warmth. Check three other bursa for bogginess or swelling. Palpate the prepatellar bursa. Palpate over the anserine bursa on the posterior medial side of the knee between the MCL and the tendons inserting on the medial tibial and plateau. On the posterior surface with the leg extended, check the medial aspect of the popliteal fossa. Tenderness over the tendon or inability to extend the knee suggests a partial or complete tear of the patellar tendon. Now access knee range of motion. In flexion, patient's instructions will be bend or flex the knee. In extension, straighten the leg. In external rotation, leg away from the midline, and in internal rotation, leg toward the midline. There are three tests for detecting fluid in the knee joint. First, bulge sign. With the knee extended, place the left hand above the knee and apply pressure on the suprapatellar pouch, displacing fluid downward, and tap on lateral side. Place the thumb and index finger of right hand on each side of the patella. With the left hand, compress the suprapatellar pouch against the femur. Palpate for fluid ejected or ballooning into the spaces next to the patella under your right thumb and index finger. If you feel fluid vibration to your thumb and index, it is positive for balloon sign. For ballooning the patella to access large effusions, we can also compress the suprapatellar pouch and ballute, or push the patella sharply against the femur. Watch for fluid returning to the suprapatellar pouch. A palpable fluid wave returning into the pouch is also a positive test for a major effusion. In McMurray test, with the patient supine, grasp the heel and flex the knee. From the heel, externally rotate the lower leg, then push on the lateral side to apply a valgus stress on the medial side of the joint. At the same time, slowly extend the lower leg in external rotation. And now valgus test or abduction stress test. With the patient supine and the knee slightly flexed, move the thigh about 30 degrees laterally and to the side of the table. Place one hand against the lateral knee to stabilize the femur and the other hand around the medial ankle. Push medially against the knee and push laterally at the ankle to open the knee joint on the medial side. This is the valgus stress test. Pain or gap in the medial joint line is a positive test for the MCL injury. Now varus test or adduction stress test. With the thigh and knee in the same position, change your position so that you can place on one hand against the medial surface of the knee and the other around the lateral ankle. Push laterally against the knee and pull medially at the ankle to open the knee joint on the lateral side. In anterior drawer sign, with the patient supine, hips flexed and knees flexed to 90 degrees, draw the tibia forward and observe if it slides forward like a drawer from under the femur. Compare the degree of forward movement with that of the opposite knee. And now the Lachman test. Place the knee in 15 degrees of the flexion and external rotation. Grasp the distal femur on the lateral side with one hand and the proximal tibia on the medial side of with the other. With the thumb of the tibial hand on the joint line, simultaneously pull the tibia forward and the femur back. Estimate the degree of forward excursion. This is Lachman test. And the last one is posterior drawer sign. Position the patient and place your hands in the positions described from the anterior drawer test. Push the tibia posteriorly and observe the degree of backward movement in the femur. Okay, now this completes your examination. Thanks for your cooperation.